All right, let's dive right into this explainer on cerebral abscesses. We are mapping out the whole shebang today, going from the initial clinical presentation to the absolutely fascinating biological pathways these infections use to break into the brain's ultimate security system. If you've ever wondered how a localized infection manages to pull off a heist and cross right into the brain, you are definitely in the right place.
So, here's our roadmap for today. We'll start by building a profile of a cerebral abscess, figure out how to recognize the culprit, and then we're going to track down the major vectors: hematogenous spread, contiguous spread, and finally, traumatic and surgical vectors.
All right, part 1. The profile of a cerebral abscess. Let's look at the epidemiology. Basically, who's actually getting these and how often?
In the United States, we're looking at roughly 1,500 to 2,500 cases every year. Now, that might sound relatively rare domestically, but keep in mind, the incidence is significantly higher in developing countries. This is very much a global threat, and it really scales with healthcare access and how well we treat primary infections.
When we check out the patient demographics, there's actually a really distinct lean towards males that have a significantly higher incidence rate. We're talking a ratio of about 1.5 to 3 cases for every single female case.
Moving into part 2, recognizing the culprit. What does this actually look like when a patient walks through your clinic doors?
Well, the symptoms can be super deceptive because they often mimic other mass lesions in the brain. But here's the kicker: they progress incredibly rapidly. In the lab, you might just see a normal or maybe slightly elevated peripheral white blood cell count, but you are almost always going to spot an elevated CRP or C-reactive protein. And when you culture it, Streptococcus is the most common organism you'll find. Oh, and definitely lock this detail in. Up to 60% of these infections are polymicrobial. That means multiple types of bacteria are literally teaming up together to form the abscess.
Now, imaging is how we really crack this case visually. On the standard CT or MRI, you're usually hunting for a round lesion that has this thin, enhancing ring. If you look at a T2-weighted MRI, it'll show a high-signal lesion with a thin, low-intensity rim all surrounded by high-signal edema. But you know, the real golden ticket for diagnosis here is diffusion-weighted imaging, or DWI. Finding a core of restricted diffusion, that's an absolutely crucial feature that helps us differentiate an infectious abscess from just a standard brain tumor.
So how do we neutralize the threat once we've spotted it? The standard treatment protocol leans heavily, and I mean heavily, on intravenous antibiotics. This is very often paired with simple needle drainage, in select cases, to relieve that pressure and clear out the infection. Outright surgical excision, like actually going in and cutting the abscess out completely, is pretty infrequently used these days. We mostly reserve that for fungal infections or highly resistant abscesses.
Let's take a quick look at how the nature of this disease has totally transformed over time. Historically, like pre-1980, contiguous spread, meaning an infection spreading directly from a nearby area, was the #1 source. But in our modern era, hematogenous or blood-borne dissemination has completely taken the lead. But here is the wild part. Even with all our modern diagnostic tools, we're still facing this persistent mystery. In 10 to 60% of cases, there is absolutely zero identifiable source. None.
All right, that brings us to part 3. Vector 1. Hematogenous spread.
So unlike other vectors that typically just cause a single localized problem, these blood-borne hematogenous attacks are incredibly aggressive and widespread. They actually result in multiple abscesses in 10 to 50% of cases. And if you're trying to track down the origin point of this systemic invasion, look at the chest. The chest is overwhelmingly the most common staging ground for these bacteria to launch their attack.
Now, those origins actually diverge sharply depending on who you're treating. For adults, the primary hematogenous sources are pulmonary. A long abscess is the most common, followed right behind by bronchiectasis and empyema. But for kids, the risk profile totally shifts. Children are primarily at risk because of congenital cyanotic heart disease, or CCHD. Let's break down why that happens. For kids with CCHD, specifically conditions like tetralogy of Fallot, the actual mechanics of their heart fail them. Their right-to-left shunts completely bypass the lungs' biological filtering system, which effectively sends bacteria, very often just standard strep oral flora, straight up to the brain. Plus, increased hematocrit and low PO2 create this highly hypoxic environment, which is just absolutely ideal for abscesses to proliferate. And when you add in coexisting coagulation defects, managing these patients gets incredibly complicated. Aside from the heart and lungs, there are a few other notable blood-borne sources to keep on your radar. You've got pulmonary arteriovenous fistulas, and actually, roughly 50% of these are linked to Osler-Weber-Rendu syndrome. Of those, About 5% will eventually develop a cerebral abscess. We also see bacterial endocarditis, although it's quite rare, and it's definitely more associated with acute rather than subacute cases. Oh, and don't forget dental abscesses. They can act as a really subtle but incredibly dangerous entry point. And we definitely can't overlook the stealthier, hidden pathways. For example, pelvic gastrointestinal infections can actually access the brain directly via Batson's plexus. That's a network of valveless veins that essentially bypasses normal systemic blood return and climbs straight up the spine. Crazy, right? Also, prior cerebral infarctions, meaning areas of past brain tissue damage from strokes, massively elevate the risk. They essentially act like literal magnets for septic embolization.
Okay, moving on to Part 4. Vector 2, contiguous, or direct anatomical spread.
Contiguous spread is exactly what it sounds like, a direct local invasion. The infection spills over from purulent sinusitis via local osteomyelitis, which is a bone infection, or through phlebitis of the emissary veins draining the skull. Because this is a direct physical spillover, these abscesses are virtually always singular lesions. What's really interesting here is that this vector is incredibly rare in infants. And why? Simply because babies haven't developed the aerated pyronasal and mastoid air cells needed for the infection to take hold in the first place.
So let's quickly map out the 3 main contiguous paths. Path number 1 starts right in the middle ear and mastoid air sinus. Basically, an active chronic otitis media or mastoid infection spreads directly into the temporal lobe and cerebellum. To put this into perspective, the compounding lifetime risk for a 30-year-old walking around with active chronic otitis media sits at about a 1 in 200 chance of developing a brain abscess. Path number 2 involves ethmoidal or frontal sinusitis or odontogenic, meaning dental, infections. These guys will push directly into the frontal lobe. Now, odontogenic spread is fairly rare, but when it does happen, it's highly associated with the patient having had a dental procedure within the past 4 weeks.
Then there's path 3, which originates as an infection in the sphenoid sinus. Now, even though the sphenoid sinus is the least common location for sinusitis, its anatomical proximity makes it highly dangerous. It allows for a direct venous extension right into the adjacent cavernous sinus, which then easily spreads straight into the temporal lobe.
Finally, we arrive at Part 5, traumatic and surgical vectors. When we're talking about physically breaching the skull barrier, civilian gunshot wounds actually carry a surprisingly low risk of abscess formation, assuming, of course, that prophylactic antibiotics are used. But the danger spikes dramatically if you have unrepaired CSF leaks, especially if an air sinus was traversed. We also see these breaches happening as post-neurosurgical complications. They are heavily associated with medical hardware that's inserted directly into the skull, like intracranial pressure monitors or halo traction pins.
Now, there is a super stark divergence in how we treat these. While standard abscesses are generally addressed with just IV antibiotics and simple needle aspiration, penetrating trauma abscesses play by completely different rules. You absolutely cannot treat them with simple aspiration. They require aggressive, open surgical debridement to meticulously clean out any embedded foreign matter and devitalize tissue. It's a much more intense process.
So we've systematically tracked down the profile, the clinical culprits, and the exact known vectors. Everything from bloodborne pathways to physical skull breaches. But all of this leaves us with one incredibly compelling question. If up to 60% of cerebral abscesses still present with absolutely no identifiable source, what hidden biological pathways are still completely undiscovered in the human body? It's a profound mystery that medical science is literally still racing to solve. Thanks for walking through this explainer with me. Keep your curiosity sharp, and I'll catch you in the next one.